monetarily, we have like education, employment, they don't want to go to work, they're lazy, low income, disabilities, life and health insurance problem, bariatric furniture and aids, oversized clothing, weight programs, as well as for mechanical, they have all kinds of diseases which you see like the pain, reflux diseases, plantar fasciitis. In the metabolic, we have diabetes, hyperlipidemia, hypertension, PCOS, polycystic ovaries, infertility, cancers, gallbladder disease, and etc. So you can see that there's a lot of complications and barriers goes with the 4Ms. Now, obesity, we all know is epidemic. And according to the WHO, the chronic conditions are characterized by abnormal excess fat accumulation leading to excess morbidity, where we have the BMI more than 30 kilograms per square meter. And most of you have seen this, or who didn't see it, we have a grading for classification for, according to the WHO, for the obesity. Severe underweight when they have the BMI, which is the kilogram divided by square meter, they are at very high risk of malnutrition. Both the obesity grade 3 and the very severely undernourished, they have very high underweight and risk for malnutrition, risk of diseases. Very severely underweight, less than 15, severely underweight from 15 to 15.9, we have elevated associated risk of diseases. We have underweight where we have 18 to 20, underweight, 15.9 to 18.7, we have low risk of associated diseases. 18 to 24, we have very low risk of associated diseases. Overweight start going up again. The risk of having diseases. Similarly, for the obesity with different grades 1, 2, and 3, the more the grade, the higher the risk of having a problem and having diseases. In all over, we know that worldwide obesity is more than 30%. Now, BMI, we all like BMI. BMI is really an accurate one, but in certain cases, such as we overestimate or underestimate the body fat. It doesn't really distinguish between it's a body fat or a muscle mass. So which is more weight than the fat. The muscle mass, we all know that it weighs more than fat. Like in the athletes or the players, they sometimes label them as an obese, while the BMI is even below. It's like Michael Jordan, his weight is 150 kilogram. When you go for taking the height to weight, to his height, he is obese. But when you go to calculate it with a BIA, for example, he have only 9 grams of fat, so he's very healthy. So sometimes it's not a very proper indication. We have also limitation of the BMI, body mass index, such as when they have edema, when they have a problem with metabolic disorder. You cannot consider the BMI as an accurate edema. Definitely, every day if you measure the patient, you will see a difference in the weight. Today, like 95, for tomorrow is 95.7, after tomorrow it's 90. So this fluctuation due to edema, it doesn't, ascites as well. So there's so many examples of limitation of using the BMI. Now, let's go for this, let's see this logarithm together and okay, now what happens that we do the patient's encounter, we take the history for the patient, the 24-hour recall, and the history about eating. We take the history of the BMI. If their BMI is 25, if yes, we take the circumference, height, measure the height as well, and we take the head circumference. We take the measurement of if the BMI is not within the past 2 years, it's not 25 and more, then we go for the second step by taking the waist circumference, BMI 25 or waist circumference more than 89 or more than 180, 102 for the males. If yes, we assess the risk of any kind of cardiovascular disease or diabetes. If we go for, if the BMI is 30 or 25 to 29, waist circumference, again with the same range. If yes, then the clinician will, the patient, clinician and the patient, they put the goal for the treatment for weight loss to go back for the normal body weight and healthy body weight. If it reached, we go for the progress that made and achieved. If not, if yes, then we maintain. If yes, we do a periodic check. If no, then we assess why he didn't reach. I don't know if the arrow is showing why I'm on the right side of the screen. If no, then we see why we assess the failure of the weight loss. Now we go back. If the BMI is 25, we go to the left of the screen. If the history of BMI 25, if yes, we advise to maintain the weight. If it didn't, does the patient wants to lose weight more to stay healthy, then we put the regimen. If no, we do a periodic check to remain 25. Now, if the patient history of BMI is 25, if no, then we brief reinforcement of education and weight management with a periodic check for the patients. Now, this is the power of what we should do when we have obesity. This will explain first when there is an obesity, we have to have the readiness of the patients to do the changes and to follow the rules. We do the medical education. This is with the obesity assessment period. We do the dietary evaluation, psychological evaluation, and then we put the constant therapy for that patient. Then we go for intense weight loss intervention phase, where we do a reduction of calories, increase the physical activities, change some behavioral programs, and then we go for the second level after that. If he didn't succeed, we go for therapy, whether it's medication, endoscopy, surgery, and weight maintenance. If we reached where we go for normal calorie, exercises remains the same, behavioral changes have been done, so we maintain them, and we reassess and we monitor the last one where we prevent any regain for our patient, because here we were mostly in the maintenance zone, the green zone, where we lose most of the patients because they don't have patient to continue. So we give them the health choices, we go for community support, we do some kind of further intervention to prevent the obesity. Now, when we talk about BMI and fat muscles, when we assess the obesity, we take the body fat, BF, we take the fat-free muscles, we measure the skeletal muscle mass, the metabolic active body cells mass, and the bone mass, and we take also the total amount of water. And this is measured by the biomedical impedance. Also, we measure the BMI. We take any kind of genetic or metabolic factors, the waist circumference for females and males, and we said for females should be less than 88, and for males should be less than 102. Also, we can take the waist to hip ratio. For men, it should be not more than 0.95, and for women, less than 0.8. Take the percentage of body fat, and this it can be done easily by the bioelectrical impedance analysis. Now, also we have, you saw so many, let's say, so many types of tools that we can use for assessing the obesity. For we have the DEXA, we have the MRI, we have the REE prediction, that equation. We have more techniques in water, the 3DPCs, which is the quantitative magnetic response. We have the near-infrared interference. All this, it depends on your budget. What do you have in your hospital? And we might go for the simple tools, which is the wheels or the meters or the skin fold thickness. Like when I have one patient who have a pacemaker, I cannot put her in the BIR because of the or of the radiation, unless I must under they because they have to correct again after I put her on the BIA or on the DEXA or in the MRI or any of these that have electrical waves. They have to rechange the pacemaker and reallocate it again. So I have to look into my patient and I have to make sure that I'm doing the proper tool to fit his condition. Now, the bioelectrical impedance, the BIA, which is very common, very easy to use, it gives me around 98. It depends on the sample you have or on the machine you have. It predicts the total water, the fat-free mass, the fat and indirectly fat mass. It have more than frequency. We have the signal frequency, BIA, which is not to be used for body composition. It's only for if you have a study or a theory. The human body, because we have our human body is a cylinder with constant resistance. We have the segmental BIA, tetra or 8-polar BIA. It goes with the human body, which have a complex shape. It combines several impedance measurements, and it overestimates usually the body fat in obese patients. Now we have the multi-frequency BIA, which we for the assessment of obesity, where we use more than multiple electrical frequencies. It is very accurate for total body water and extracellular water. And this is, by the way, this is a very beautiful tool when you have patients with obesity, with edema. It will give you exactly intracellular total body water, extracellular water, and you will know whether it's a fat or it's an edema, this weight. Overweight estimated, underweight estimated for the total and truncal fat. Fatness specific BIA, where it is validated for the use in obesity, and in that case, more researchers are used. Now we have the DEXA, where we have also the dual energy X-ray that it is used for. It measures the bone mineral fat. It gives you the fats even in the bone minerals. It measures all the fat tissues, all the fat-free soft tissues as well. It is an expensive and, let's say, not very handy. We determine the abnormal obesity. We predict if there is any intra-abdominal fat. It assesses the regional body composition. It's very beautiful if you're doing a very good study for your patients, but it is very high cost. It's you can train appropriate for trained staff. Not everybody can use it. You have to delegate somebody special for that. Also, very, let's say, huge bodies above 300 or 250 cannot be measured on that for severe. Above 150 kilogram, and its width it's only 60 centimeters. Now CT also measures the muscle mass. It shows you when it comes out all the visceral organs, volumes. It shows you the visceral adipose tissues. High radiation, you're unnecessarily giving your patient unless it's a must. A radiation, high cost. Similarly, the MRI measures all your body composition. It gives you regional fat, but limited size on the MRI, again, not more than 150, and it's again high in cost. We have also the resting energy expenditure in obesity, where different equations exist for the calculations. Accuracy of equations are varied, limited clinical practice, and there's a new periodic equation for severe obese patients are, it is needed to be done. Now, also there is overcoming anthropometric assessment where it is found. There's a lot of equations or systems are adapted. You can Google them and you can study them if you like them, but it's very popular in Europe where they have the Edmonton, and it is used for studies and research of obesity staging system, EOSS. They have the European Association for the Study of Obesity. We have also the obesity as a obesity-based chronic diseases, where they have a lot of tools for anthropometric overcoming the, and you don't have to take the measurement of the BIA. You just, they have like equations and scales to follow for the studies. Now, the optimal BMI and mortality, we know that if we have, imagine, just a BMI more than 25, it is associated with cardiovascular diseases, hypertension, diabetes, stroke, cancer, colon or endometrial cancer. If the patient having more than 40, rarely they live longer than 60 years, they measure their BMI changes is better than static BMI measurement, and the optimal BMI from 20 to 22. I'm sure that you have heard about, especially now with the pandemic as well, the obesity paradox, where we have higher BMI, longer survival. The obesity paradox works with certain cases, yes, where we have peripheral lower body fat, sometimes unknown factors, genetics, increased lean body mass, decline CVD's risk factors. It's associated with even inflammatory response. Let's see how it is, what's happening in this paradox. Usually, they say when you have a bit of obesity, which we don't talk about the grade 3 or grade 2 or grade 1, we just talk about regular obesity. It has shown that lower attention of physical function in patients with chronic diseases, reduction of oxidative stress and inflammation, lowers level of B-type peptides, which lead to regional systematic activity, provision of favorable function lipids profile, and secretion of adipokinase, which provide cardiovascular benefits. So they found out that when you have obesity in general, we have higher mortality, but in certain cases, such elderly, cardiovascular diseases, ICU, dialysis, cancer, patients with peripheral vascular disease, some hospitalized patients, actually it makes it like what I say, which we will see, it more begin to prognose even in advanced stages that if they have BMI 35 and more, their mortality rate is even less than the patients who have, on those cases, they have BMI which is very low, like 20, 22. That's why in elderly, according to the most of studies and research, they have increased the optimal BIA for them who are people age more than 65, not from 20 to 24.9, it becomes 28. Why? They correlated, they have measured the death for the, you can see different age group, 35 to 49, 50 to 69, and 70 to 89. And they found out that patients who have the mean BMI, which they took for all of them, is around 25. And they found out that patients who have elderly from above 69 with BMI 25, their mortality rate were higher, while when they reach to 28, their mortality rate become less. Cardiovascular diseases, when obesity and cardiovascular diseases are there, especially class 1, which is not severe obesity, the obesity patients present better prognosis than normal or underweight patients. I know that's why we call it. I can feel that some are questioning this. Yes, a lot of studies on that, and really it's still further questions, but they show a better prognosis. Maybe to fight, because when you are in severe cardiovascular disease and you are you have a catabolic status high, so when you have a little bit of fat, maybe the resistance is better. Lean mass is associated to improve the cardiovascular fitness and increase the lean mass stronger than fat mass. Heart failure patients, you can see also there is a study which have been done by Kaplan and Mirror, analyzed, where you can see the BMI different colors, A, B, C, A where the BMI is 30, the blue one where 25 to 29, and the BMI where in the green is 18 to 24.9. And you can see the accumulation survivor for patients who have more than 30 and 25 to 29 better than the one from 18 to 24. Also in the ICU patient, the mortality of an obese patient is less than the one normal or underweight patient. And I'm talking about not 40 or 55 or 50, we are talking about 30, 25 to 30 only. And you can see also that the study which have been done on the BMI and the mortality rates, there's a lot of studies which is, you can find them in my reference now at the end of the study, where it shows that the mortality rate for patients who their BMI was from 25 to 30, the mortality rate were lower and they recovered, or they are even in better status than who have normal or underweight patients. Dialysis patients as well, they show a protective effect during dialysis with patients with high BMI, again, high BMI 25 to 30. I'm not talking about above 30 to 50 or 40, because that's another high risk. Lower BMI, where is risk factors of death. Cancer patients, and this is, I saw it with my own eyes in some of my patients actually. Malnutrition is really associated when they have a very low BMI, low weight. They're fighting and reducing survival. Survival time of obesity and overweight is very much higher in those patients with cancer. And higher BMI decreases the disease-related mortality. And higher BMI decreases the reoccurrence rate, but worse prognosis with sarcopenic patients. When they have sarcopenia, khalas, that means no muscles, nothing, and they usually don't survive. Now with the peripheral vascular as well, underweight patients, double risk of dying, overweight patients, half risk of dying, hospitalized patient, optimal BMI-C. We didn't go to the 35 or 40s or 50s. It's optimal from 28 to 33 for hospitalized patients. Why is that? To have a better defense mechanism during their stay in their hospital. Look at this. This is the three different, on this slide you can see, when you have patients with high BMI, metabolically healthy, obese fitness. We're not talking about patients who is having more than 35 BMI, who's having diseases. We're talking about patients who's having high BMI, healthy, improve energy reserve. They have anti-tumor adipokinase. Normal patients goes with BMI where you have, up to 25 and little bit more. It presents sarcopenia, obesity, muscles loss. where you have, you can see in the low BMI, they have fat loss and atrophy, they have sarcopenia and muscles loss and weakness, they have cachexia and unhealthy lean body mass. So we have to be logical when we have patients in-house, in the hospital, and what is our aim? We have to check their fats and their conditions to improve their prognosis and survival. Now, obesity and health, we all know that. We all agree that we have to be realistic. Most of the people who targeting ideal weight are unrealistic, unnecessarily, because you will not achieve it. You have to have a moderate weight loss from 5 to 10%, and we have to demonstrate the effect on type 2 diabetes, cardiovascular diseases, tumors. We have to make sure when we put the goal that we know what we are doing. And the most important thing is my patient going to implement, to follow. This is your key of success if you want to put any kind of diet. Now, obesity, sedentary and lifestyle. We have sedentary life behaviors that we have to change, such as TV, cognitive work, to physical, to increase it. Sleeping less time, we have to put it 7 hours and above. We have big studies, big ones, talking about sleeping and weight gain. Less sleeping, more weight gain, more good sleeping, seven. Of course, by age, it differs. You have to look into the age group and see how many hours they should sleep. Over consuming of fat and carbohydrate can lead to obesity and overweight in both young and adult age. Unhealthy dietary behaviors also will lead to obesity and overweight. So what I will have to do, I will start gradually with deducting 500 to 1,000 calories from the daily intake of that patient. I put women from 1,000 to 1,200. Of course, it's individualized and differs. Men from 1,200 to 1,600. Again, it differs on weight and height and activities and sport they are doing. But I reduce 500 to 1,000 kilocalories per day to reach to reduction of 0.5 to 1 kilogram per week from the fat. Now, effect of nutrients on protein, carbohydrates, fats when we do any on obesity. We have the effect of protein on obesity. It's a very, and so many people are using this high protein diets and low carb diets because and increase the protein. Why? Because it's protein is related with satiety. It have a direct effect. And absolute protein intake more than the percentage which is needed, 10 to 15% of the WHO, it might decrease the leptin food intake where when we go up to 20 to 30%, which will decrease the AD leptin food intake. And it have very difficulties of maintenance, and it shows that low protein diet on the long run can also can lead to so many problems such as stress, depression. So we have to be realistic and follow the proper guidelines when we want to do an obesity. And even if you want to go for low carb diet, you have to do them not for a long time. You have to monitor them and you have to observe them. Effect of fat, there's a meta-analysis with regard of lower percentage of fat done on a very huge number of patients, participants, 74,000 participants. There is a 33 randomized controlled trials for 6 months to 8 years, small but clinically meaningful sustained reduction of overweight on obesity and reduction of body weight, BMI, waist circumference, both healthy and in risk was there, but again for a period of time. Now, the effect of dietary sugar, we all know that regular sugar have a problem on obesity. It's an empty calories. Debate, there was a lot of debate going on in so many years and still going on the role of the sugars and the substitute sugars of overweight or obesity. And there's an obvious track to obesity or overweight of dietary sugars. There was a very so many cohort studies where the meal replacement or the sugar sweetened beverages, they have the largest source of sugar added, not only in USA, but this study was in USA in 2013 in the Journal of Clinical Nutrition. Um, Also, it is the top source of energy in the USA. When they decrease this sugar sweetened beverages, they show a big reduction in overweight as well as obesity prevalence. So prevention through limitation of these sugars should be low, which you can see that it have been there in the strategies which they put to overcome the obesity. The effect of dietary salt also is there, and the analysis of the food consumption, we saw that even in Darbold, this is in Australia, which was published again in the Nutrition Journal in 2013, that dietary salt intake and sugar sweetened composition and obesity risk. They found that in this study as well, they analyzed the children in Australia from 2 to 16, and they found that they don't drink water, they have a lot of salt, and salt reduction strategy should be there because there's a correlation between high intake of salt as well as obesity. Now, what are the strategies? What we should do? Now, there's four pillars we should take. First, we have to increase the health promotion, which is in the green color, where we do food retail, we go for the provisions for school, work sites, built environment, park, and recreation transport. In the red color, we reduce to a healthy behavior. We promote we stop promotion for the unhealthy products. We try to minimize it. We put under them, which we did in UAE, a higher cost of unhealthy beverages. We put like a taxes on them, and this is what have been done, higher taxes. But we can see that also in the healthy food, it's higher in cost. We have to reduce that. Lead to a personal safety, discrimination, and social exclusion. We build in the violet color the community capacity where we empower the communities. We put strategic partnership. We change the behavior and knowledge and skills. We promote for healthier behavior. In the blue one, where we improve our social and economic resources for anti-hunger programs, in other words, economic development, legal services, education, not education for the people, but also doing a job training for the employees, housing and taxes credit where we have implement this in UAE. Now, also in the healthy and weight management, we have to see the comparison which Cardiol have done in his study in 2018, healthy weight versus obesity, and what should be done. First, we have to check the pathophysiological and psychological effect of obesity, which is hemodynamic, morphogenic, metabolic alteration. We have to go for the behavioral consequences of obesity. And when understanding the consequences, then it is very easy to see the differences of healthy obesity and obesity paradox, which I have spoke about in cardiovascular disease patients, for example. Also, we go for the mechanistic triggers factors, such as the dietary calories, the refined carbohydrates, such as simple sugars, physical activities versus sedentary activities. Also, we go for the prevention and treatment. Similarly to tobacco and weight management, the burdens of diet patterns versus the specific dietary component, evidence on dietary quality, the community prevention, the sedentary behavior, the pharmaco and bariatric surgery, which we can see it a lot nowadays, the genetics, all this also we should look into it. The caregiver promotion, health promotion, we go for the obesity that it's as a leading modifiable risk factor of chronic disease. We emphasize on the prevention versus the treatment. We are going directly to the bariatric, we are going directly to the medication. Why? Go for the prevention. To prevent, you will not have a problem. To treat, the problem will still remaining and existing. We go for a healthy lifestyle. We go for recommendation for evolving training among healthcare professionals. Let them understand, then the implementation will be much easier to do and easier to implement. Now, what are the strategies? One, we make sure that the consumer education on the why, if what is the problem if I have an excess of calories? I have to let them know and read the food label and probably the interpreting calorie claims and making healthy food. Today, this year, the Gulf Society, اللجنة الخليجية للتغذية, the Gulf Nutrition Society, they have put one day in March, 1 week in March, for health promotion, nutrition health promotion, and they have put the label this year. They targeted the food label and they put it in red, green, and yellow. I'm sure you saw it in Ministry of Health, in DHA. They have put the announcements. We have spoken about this in that month to just educate people about how much the calorie excess is harmful and how to read the label and how to make the right choices. So many people doesn't know how to read the label, and this is our duty as a nutritionist and the clinical dietitians and physicians, pharmacists, to know, to teach our people how to read whatever they are having in their stomach. Cutting down the calories by consuming low calorie food, low calorie beverages, fatty snacks, adopting diet known as to lower the blood sugar, blood pressure, high blood disease. I love the DASH. I love the Mediterranean diet, the TL, the lifestyle diet as well. It's a beautiful diet, easy. There's a variety in them, and they have a beautiful influence on our sugar, on our lipid profile, and on our weight. Also, we have to make sure to increase the physical activities. You don't have to go to a gym. Simply tell them to reach to the 10,000 steps if they want to reduce weight. You know, the regular people, if they want to maintain from 4,000 to 8,000 steps a day, if they want to maintain their body weight. But if they want to reduce, they start to have the 10,000 steps a day. Simple. You exercise, decrease the standing time, make sure that you do a good lifestyle, food proportions, food size. We have to make sure to tell them what are the exact size. Use my plate. Half of the plate fruit and vegetables, and the half is between carbohydrates and proteins. Easy to implement. Also, for the recent 2015 healthy food pattern that emphasized on reduction of sugar, excess of fat, and salt, and following the health professionals' 2020 guidelines, where we use more vegetables, more fruits, more greenery, and reduction of fats and salts and sugars. Also, gradual sugar and food reduction. We need 21 days to change our habit. 21 days. Convince your patient to follow your diet for 21 days minimum, because if they want to adapt anything like reduction of sugar, reduction of salt, your buds needs 21 days to adapt. So go to that, then you will succeed with your patients. Behavior and life modification, the sleep. The more you sleep, the less stress, the better weight reduction. Eating in moderation and high calories. Have fun. Food is beautiful. Food is tasty, but you know how much to eat and when to eat. Also, eating mood is to promote a healthy and natural tradition, as they may be also high in calories. We have to make sure what we are having. So many patients comes, I'm having the protein bread. but I'm not reducing weight. Who told you if you have like exact amount, it have calories? You have to tell them. You have to read the calories in that, because if you are having 5 or 6, it it you didn't do anything. Still calories are there, so you will not reduce weight. Researchers before food before eating, whether at home, in restaurants, if they have a good options for you, tell them to look into whatever the menu is there and select that, teach them how to select the healthy choice. So you can enjoy your social life, but you have to be smart in eating. Make healthier food choices and observe the counting while you're doing that. Limit unhealthy food, limit unhealthy beverages, limit the television time, and we as a government, we should put laws and policies for good physical activities and food and health and nutrition. And from here, I would like to salute and say my extreme admire to the Saudi FDA. Honestly, they have a beautiful outcome. Also, the Saudi society, they have also a very good brochures, guidelines. They are educating people. I love what they are doing. Keep up the good job. If anybody from Saudi Arabia with us, use also for the use of sustainable obesity, we have to involve not only the affected people to feel that he have like a disease. No, the whole family have to be healthy, the whole facility have to be healthy, all the surroundings should be healthy, all our country should be healthy. We have to encourage people to go for the walk. It's the cheapest we have in our country in UAE. Thank God, our sheikhs, they have built a beautiful walks for the people, for their cycling, for their walking, for their swimming. Beautiful sites. Use them, cheap but very effective. In summary, the obesity, we all know that it's epidemic and it's really a problem in all countries. We have to encounter our efforts to fight this problem. All healthcare workers and individuals should know how to really assess the obesity in private, clinical, or community settings. They should also be conversant with the various causes of the obesity, and how much the obesity cause our government. It's really cost effective if I do the prevention rather than do the treatment. So we have to make sure that we are using friendly, easy, adopting practical, regularly health living for our patient, and we really make sure to increase our public health education on excess weight gain. Also, we have to make sure to inform our public to be enabled to do a proper action in better food choices. Healthy public will save healthcare money and save the lives if they just follow the proper health guide and limiting the unhealthy food, increase their healthy physical activities, and improve their sleeping and reduction of stress, put a concrete effort by individual, health professionals, business, and government. All should work together for the wellness of our country. I go back for the wheel to tell you that it is a phases, obesity assessment, intense weight management, and then we go for weight maintenance to prevent any kind of weight regain. By that, I end, and these are all my references. Thank you very much, and I'm open for any kind of questions. Thank you.
Thank you so much, Dr. Wapa. But before we proceed with the questions from the
Yes.
participants, we would like to invite one of the specialized beauty group promoter, Mr.
Yes.
Sashan, Engineer Sashan, to speak with us the related body composition analysis to our webinar for tonight. Mr. Sashan?
Hello.
Hi, Mr.
Hi.
Sashan. Hi.
So can you hear me now?
Yes. Can you please share your screen?
Okay, sure. Can you see my screen now?
Yes, Mr. Sushan.
Okay, so now thank you very much for providing me an opportunity to talk about the topic related to the obesity assessment. And well, Dr. Wafai, she actually covered most of the topics related to the in-body technology and accuracy. And since in-body is already a very popular and most preferred device among the healthcare professionals, so I'll be more talking about the commercial aspects of the in-body and how you can make a difference in your practice by having an in-body device. Okay, so as discussed, and I'm always referring to the presentation of Dr. Wafa, that rather than BMI or weight, the body composition has a lot more meaning. So when you see an iceberg, okay, so you can really see that it's just a tip. So there is a lot of the actual icebergs lies beneath the sea level. Okay, so the same applies for the body composition, despite the level of the BMI weight, there is much more information that can be obtained through the actual body composition. So there are many limitations in treating a patient condition with BMI or weight. So however, what is the certain is that the importance and awareness of body composition continues to increase more than before. So here, it arises a question that why should you look at the body composition? So why you need a body composition. So I'm going to highlight three major factors that why you need a body composition analyzer. With the help of a BCA device, actually it provides a more opportunity to talk more with abundant information. You can create and enhance your business model, and you can monitor the progress and successive self-motivation. Okay, so let's consider a case where a patient walks in without a BCA screening. And when I say like BCA is a body composition analyzer, so what initial possible questions you can ask from them? So what are the symptoms? What is their main concerns, or what made them to come up in the healthcare facilities, etc. So, or else you will provide them a very long questionnaire, maybe something like this, and you keep asking questions to keep the track of their systems. So it's a long procedure a patient has to go through. Okay, but screening with a BCA device will provide you the first-hand information about the patient's body. So in less than 2 minutes, you can have a detailed report. So now you can talk more about why there is a low muscle, okay, and where the lot of fats located segmentally in the body. You can really track the body balancing. You can do the circulation check, overall cell nourishment. Okay, so now with the help of a BCA device, you can talk more about certain parameters. Again, as what I said, like when you see the sarcopenia, okay, so you can really see the causes of the what are the causes and what are the solutions. So what is in body results is giving you an opportunity to add more services. Let's say you can introduce the exercise intervention, okay, or if you consider the high visceral fat information, so you can also look for the causes and the possible solutions. And you can indicate the edema. You can check the causes of the edema. It can be due to the inflammation, low immunity. It could be because of the complications or toxicity. Okay, so you can also implement the precise examination like metabolic tests, NK cell tests, or hair mineral tests, etc. Okay, so and when you see the upper and lower body balancing, so and it can be because of the poor lifestyle. You can really look into it, and you can plan your dietary programs or suggest nutritional supplements. In this way, you start to add more services to your program. Okay, so this consultation will provide you the opportunity to talk more with the patients and thus increase the patient's satisfaction. Okay, so second, there are so many things you can connect with your business, because now anybody helps you to create your and enhance your business models. So such as you can when you make a diagnosis, you can refer to the indicators what I just mentioned. Moreover, in body results will provide you an opportunity that to connect fully with the patients, not only with the diagnosis but also prescription, and you can enhance your business also. For example, you can suggest them some supplements. So I give you some examples here. Like by knowing the actual body composition, you can suggest them the protein supplements, mineral supplements. There are many other supplements also. Okay, important point is how you can make a better use of in-body results, okay, to enhance your business model. Okay, let's give you an example of there are some nutritional clinics that uses IV drips. Okay, you can also add the service by adding the minerals, proteins, or vitamins to your clinical applications. Or let's say now you have the visualized results. Okay, so you can really see the cell health, the body water balancing, sarcopenia, somatic cell mass, and you can add more services to your clinical practices by knowing the exact body composition and what you need to do next. Okay, so or you can have the consultation charges, or let the clients do free in-body tests with a minimal consultation fee. Okay, and how you can monitor the progress and successive cell motivation. Let's say you can really monitor the muscle fat analysis by looking at the history of the patient. Okay, let's say in this case, the patient tends to lose the weight after the bariatric surgery. But good thing is happening to him is that he is losing the weight in terms of fats, not in muscles. So really, you can track and progress the overall performance of the patient's body. Here, I'll give you another example of a dry weight calculation. Okay, so after continuous screening and dry weight calculations in dialysis patients, you will notice that the extracellular water ratio stabilizes as you start implementing the accurate dry weight calculation. And yes, anybody gives you information about the dry weight calculation, you can do the circulation check, you can do the nutrition check, specifically in the dialysis patient, apart from what you get a journal information about the body analysis. Okay, here is another example of the comparison before and after the medication of type 2 diabetes. Okay, so how you can really see that how the patient's body starts to respond after the proper medication. Okay, so I'll use an example of a UNC Cancer Rehabilitation Institute, where you can really see by having the body composition analyzer in their center, they really improve the attendance rate from 50% to 87%. And whereas the retention rate also, retention rate is the rate that people are more tends to go to the higher levels of their programs. So it's been increased also from 55 to 66%. Okay, so and just to summarize, let's say like you want to get more returning patients. So what you can offer them, a free in-body test before they fill up their script. Okay, analyze their results for and recommend any products that you can assist them with their health, or any treatments you can suggest them. You can create a reminder for them to pick up their next script and book them for a follow-up assessment. Okay, by doing this, you are showing that you care and value them. You're also visualizing their progress for them since their last visit. So chances are you have turned this into a repeat and loyal patient. Okay, so utilizing an in-body scanner within your business can help with repeat business, not only getting them back to scan, but also repurchasing any suggested products. Okay, so how all this can be achieved, like being a distributor for in-body as an spec, right? How we can help you out to achieve these targets is just to offer you free in-body demonstration trials at your own facilities. So you can reach me out, and Kim will provide you my contact information, so you can really see the complete body composition through the demonstration, free demonstration at your own facilities. So that's all. Thank you.
Thank you so much, Mr. Shashan. Before you leave us, there is a participant that is asking Ms. Shaima Madhi, can you please explain in-body score?
Hello. Okay. So in-body score, it's a parameter which really sees your body muscle fat analysis. Like a person who is having more amount of muscles with compared to the fats, so he scores more. Let's say we consider as 70 is a normal information scoring point. When you score above towards the 100, so that means you are becoming a more athlete, more muscular, with good amount of muscles and less amount of fat mass. And it varies for males and females separately. So it all depends on your programs, what you are being to introduce with. But again, when you see this in-body scoring, you need to also refer to the weight control parameter in the in-body result sheet.
All right. Another more question from Miss Danya. What is the accuracy of in-body analysis?
Okay, and body, you need to understand the basic concept of the body composition analyzer. Okay, so you need to see the validation studies. There is some electrical terminology I'm talking about, like the electrical frequencies passes through your body to calculate the impedance. So these frequencies should be validated. So being the gold, DEXA as a gold standard, okay, we have proven to be 98.4% accurate to DEXA. Okay, and this all validation studies for all the frequencies is to be validated with the DEXA scan. And I'm more than happy to provide you all the validation studies as well.
Thank you so much, Mr. Shashan. Please stay with us if there's any further questions that we have. For the meantime, can I have Dr. Wafa?
Yes, I'm with you.
Hi, Dr. Wafa.
Hi, dear.
Actually, I've been trying to see if there are any further questions from
No,
the
I went through them.
attendees.
There isn't. Yeah.
Yeah, there isn't. So before we end, Dr. Wafa, would you like to add anything or to say anything to our attendees?
I would like to say thank you very much for being with us, and I hope you have enjoyed the lecture. I would like to thank the Khif from the administration, yourself, Kim, for all the efforts. You're doing a great job. Thank you very, very much. And keep up the good job and stay safe. Thank you very much, everybody.
Thank you so much, Dr. Wawa, for your time. It is always a pleasure working with you and providing knowledge to our healthcare professionals, especially during this COVID time. It
Yeah.
is really one of the new normal. But attendees, we would like to take this opportunity to inform you that the KIF is planning to host our third Nutrition and Health Symposium on September 23, and this time it will be a physical event in Dubai. So we hope to see everyone. Dr. Wafa, we would
Oh,
love to
nice.
see you again.
Yeah. Thank you. Good luck. Good luck. Thank you, Kim.
Inshallah. Thank you so
Thank
much,
you.
Dr. Wafa, and attendees. Thank you so much for once again joining with us and staying with us for
Thank
an
you.
hour
I'd
of
like to
our
say hello to
workshop.
Najla. I can see her name as well. Thank you.
There are a lot of your DHA staff
Yeah.
here.
Thanks. Yeah. I'd
Thank you,
like to say
Dr.
hello to all of
Wafa.
them. Thank you. Bye bye.
Take
Bye
care,
bye.
Dr. Rafa. Attendees, please keep in touch for any further upcoming activities of the KIF. And as I mentioned, CME certificate of attendance will be acquired through the TAM portal of DOH. You will need to download the UAE Pass in order to access the TAM portal. We will be sending an email tomorrow after 24 hours of the webinar with a link of the post-test evaluation and a link of the step-by-step procedure, how you will have your TAM access or your UAE pass. For international attendees, we will be the one to send you your certificate. So please continue to follow the procedure, filling out the post test evaluation, and as well as a survey that we will be sharing with you through email. Thank you so much, everyone, and stay safe.